Hi, everyone. Welcome. Good evening. My name is Leslie Bordolato, and I am an improvement facilitator at the Edmonton Southside Primary Care Network. I'd like to thank everyone for joining us this evening, and we're coming to you from Edmonton, Alberta, and it's nice to see some registrants from near and far, far away, such as Ontario and even Saudi Arabia. Welcome to the Breathe Easy, Choosing the Right Lung Test for the Right Patient workshop. Tonight's workshop is in partnership with the Physician Learning Program and the Edmonton Southside Primary Care Network, as well as a special collaboration with the Medicine Strategic Clinical Network. We are presenting today from Edmonton, Alberta, and the traditional land in which we are located is in Treaty 6 territory. We acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Just some of our Zoom housekeeping items. We ask that if you could please change your name on Zoom to your full name and organization or clinic. This helps us to organize breakout rooms as well as track attendance so that we can send out certificates. So there's some instructions on the slide here on how you are able to do that. As well, we ask that you please mute yourself when you are not speaking. We'd love to see your smiling faces. Consider turning on your cameras so that everyone can see you. And there you can see some instructions there on how to do some of that with the Zoom. We do have a chat and question and answer feature on Zoom. So use the chat feature if you have a question about technical difficulties or L3 program services. Kim and Shanna are available for technical support, so feel free to message them directly in the chat box. If you have questions for speakers, we ask that you please use the Q&A feature of the webinar, and that icon is at the bottom of your screen labeled Q&A. Please review what has already been asked and upvote those questions you would like answered. We cannot guarantee that the panelists will be able to respond to all of your questions, but they will do their best. So this is our agenda for tonight. All participants will be assigned to we'll do our welcome housekeeping, which is right now. We're going to talk about linking learning to practice, my lifelong learning program. Then we will have our guest speakers. And then after that, we will do the application of learning portion of this workshop. And then there will be breakout room discussions. So all participants will be assigned to breakout rooms for discussion portion of the evening. If you are part of a primary care network, you will be with an improvement facilitator who can help you work through the action plan. And this action plan was attached in your reminder email. If you are not part of a primary care network, you will join Nandini Desai, who can discuss QI initiatives in your practice, as well as answer any questions you may have about the physician learning program. So one more webinar housekeeping. This session will be recorded, and a recording of the webinar will be available over the next couple of weeks. It will be sent via email to all those who have registered. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. Main Pro Plus participants may also earn additional credits by completing the linking to learning exercise and completing a quality improvement cycle on my lifelong learning platform. So again, welcome. And at this point, I would like to introduce Nandini Desai, who's a clinical liaison with the Physician Learning Program. Nandini?
Thank you, Leslie. Thanks for the introduction. So the Linking Learning to Praxis is a self-administered reflection exercise which provides all CFPC members with an opportunity to earn 5 certified main pro credits. The Linking Learning forms were sent to you in the email, as Leslie mentioned, but they're also available on the CFPC main pro portal and are certified as self-learning activities. So during today's session, our facilitators will assist you to formulate an action plan. Once some time has passed, typically about 6 to 12 weeks, you will need to assess the impact of your learning and complete the final reflection activity, and then submit the form to receive your credits. Next slide, please, Leslie. And another way to get your credits is through the My Lifelong Learning Plan, which is a free online tool for physicians to get their credits. It can be used to meet and support the 3 activities and the action plans that are required by the Physician Practice Improvement Program, the PPEP-CPSA program, and earn CME credits by completing the following 3 cycles. One is your practice-driven quality improvement activity using objective data. Second is your personal development. And lastly, the standards of practice quality improvement activity. Members can receive up to 12 credits by completing the QI cycle and 6 each for the personal development and standards of practice activity for a total of 24 credits. And that's it. Leslie, if you want to switch over, stop the share slide. I would like now to introduce the speakers. I'm delighted to be introducing our excellent speakers. I'll just wait for Dr.
Sorry, I'm just trying to find my share bit. There we go.
So
okay.
Perfect. Thank you, Tina. 3 speakers for today. First one, Dr. Ron Demant is a professor of medicine in the Division of Pulmonary Medicine, University of Alberta, and the section lead for the Respiratory Health Section, Medicine Strategic Clinical Network. He is trained in family medicine, internal medicine, and respirology, having practiced primary care, emergency medicine, and internal medicine in Alberta and British Columbia. Ron is currently the interim Department of Medicine site chief, and he's also the Deputy Director of the Pulmonary Medicine Division for the University of Alberta Hospital and the Edmonton Zone. He has done collaborative research in a number of areas, including online delivery of medical curricula, the impact of psychological stress on undergraduate medical student attendance, and patterns of distress among patients with advanced COPD. Our second speaker, Dr. Jacqueline Tay, is a general respirologist currently practicing in Edmonton, Alberta. She completed her medical school training for internal medicine residency and adult respirology fellowship at the University of Alberta. She began her practice in Edmonton in August of 2022 as a community respirologist, as well as with the Pulmonary Medicine Division at the University of Alberta Hospital. In her free time, she enjoys golfing, playing ball hockey, traveling, exploring the food scene in Edmonton, and spending time with her friends and family. My kind of girl. And lastly, I want to introduce Tina Nicholson. Dr. Nicholson is a UK-trained family physician practicing in Cochrane, Alberta. She has some focused areas of practice around child and youth mental health, as well as women's health, and continues to maintain a small generalist panel. She has always had an interest in medical education and optimizing practice, and has been involved in undergraduate and postgraduate teaching for many years. A position with the Calgary CME and PD offices and the Physician Learning Program has aligned these 2 areas, and she is keen to support others in achieving their own practice goals through quality CME, while recognizing the challenges of building this approach into daily practice. Constantly aiming for some balance in her work and family life, she is calling in from Kimberley, her family's happy place, and constant reminder of how lucky we are to live in this beautiful part of the world. Dr. Nicholson will also be a moderator for the Q&A session towards the end of the program. Welcome to all three speakers, and I'll let you all take it away.
Thanks so much, Nadine. That was a lovely introduction. So welcome everybody. I am just going to go through the slide deck and let you know that Dr. Tay and Dr. Demand have no affiliations or conflicts of interest to disclose. I've popped down my affiliation with the University of Calgary and also my teaching with the CanReach program. Other than that, there's nothing that is really relevant to this evening's presentation. So let's just review our learning objectives for tonight. What we're hoping is at the end of this presentation, we should be able to identify when our patients require lung function testing and actually apply the correct test for the correct patient. We're going to consider at what point they need this testing and what we use to diagnose the conditions mainly of asthma and COPD. Reflect on when we need to refer to a specialist, and also remind ourselves when we can collaborate with our teams within our PCNs and what opportunities we might have to optimize care for our patients who are living with chronic lung disease. Before we move into the meat of the presentation, I just encourage you to have a minute or two to just reflect on this part of your own patient panel. How often do you consider whether your patients with asthma or COPD have actually had a lung function test? And if so, what was it? Was it a spirometry? Was it a full PFT? And how many patients have I actually got on my list that are on an inhaler, possibly on a repeat prescription for an inhaler, who've actually never had a confirmed diagnosis through testing? With that, I'm going to hand it over to our specialist colleagues. First of all, we've got Dr. Tay.
Thank you, Tina, and thank you for the introduction, Nandini. So I'll just start off with a little bit of background about why this topic is so important and how many people it can potentially affect. Again, reflecting on your own self panel there, how many patients in your practice you may have that are on inhalers. So in Alberta, over 600,000 people have a current diagnosis of asthma or COPD. It's estimated that there are 20 to 70% of patients that are undiagnosed in Alberta that are due to the underuse of post-bronchodilator spirometry. And in the patients who have a diagnosis, in 33% of these who have been seen by a specialist, asthma could not be established objectively despite having had this diagnosis previously. Next slide. So the choosing widely guidelines, I'm sure you're all familiar with. So just to kind of touch on some of the points in the respiratory section. So a couple of points here. So don't initiate long-term maintenance inhalers in stable patients with suspected COPD if they have not had confirmation of post-bronchodilator airflow obstruction with spirometry. Don't continue medication for asthma, so inhalers, leukotriene receptor antagonists, or other medications in individuals who have not had a clear clinical benefit or confirmation of reversible airflow limitation with spirometry or peak flow testing, or when non-diagnostic, a positive methacholine or exercise challenge test, provided timely access to testing allows it. And then just kind of beyond that, just in terms of respiratory cardiopulmonary diseases, don't delay conversations about wishes and goals with patients who have serious progressive chronic respiratory illness such as COPD, IPF, pulmonary hypertension, cystic fibrosis. Unnecessary and potentially harmful treatments can be avoided by having discussions and documenting these conversations. Next slide. So what are some of the impacts of not potentially ordering these lung tests that are pretty readily available in our communities? So a false diagnosis may delay diagnosis of actual underlying conditions. So up to 6% of patients who were initially diagnosed with asthma clinically had an unrecognized serious cardiorespiratory condition. If having a false diagnosis of asthma or COPD can potentially lead to these patients being on medications unnecessarily. And with these medications, of course, come potential side effects or adverse effects. The cost of these medications must also be considered. And then the environmental stewardship or environmental impact of some of these medications and inhalers. So in terms of impacts of inhaler use, so kind of most commonly beta agonists, so our beloved Ventolin, MDIs, commonly cause things like tremor, tachycardia, palpitations, rarely metabolic disturbances. Our muscarinic antagonists can cause dry mouth, pharyngitis, and rarely urinary retention. Inhaled steroids can cause both local and systemic side effects. So local dysphonia, thrush, contact hypersensitivity, cough, perioral dermatitis, and systemic, more uncommon, but just things that can be serious as well. Adrenal suppression, respiratory infections, cataracts, reduction of bone mass density, and then potentially drug interactions as well. Next slide, please. So in terms of inhaler use and costs, so these are some of the figures that I've just pulled from the Alberta College of Family Physicians price comparison charting from 2022, averaged as the 90-day cost. So salbutamol, you can see they're pretty affordable, $25 for a 90-day cost. But when we start talking about maintenance inhalers, particularly some of the dual therapies, combination therapies, the prices certainly can get up there and become quite a financial burden, particularly if they're going to be, again, maintenance medications that are going to be, continued long term. And just as a kind of background as well, the median income of an Albertan age 16 and over in 2020 was $42,500. And in 2021, 17% of Albertans reported not having any prescription insurance whatsoever. So these can certainly become quite a financial burden over time, and certainly something important to think about. Next slide, please. And in terms of environmental stewardship, which sometimes we just, with the ease of being able to prescribe these medications, maybe something not always in the forefront of our minds, but just as sustainability and global warming are kind of becoming more important, some things to think about. So the pressurized MDIs do contain hydrofluorocarbon propellants, and while they are ozone safe and were developed to replace the CFCs as propellants and inhalers, they are still potent greenhouse gases. So they do still have high global warming potential. And just as an example, so a single dose of the hydrofluorocarbon 134A in an MDI has a carbon footprint of 200 to 300 grams of CO2 equivalent, or approximately double that of a kilometer driven in a small car. And that's one single dose. The majority of hydrofluorocarbons used in inhalers come from salbutamol, not surprisingly. And then outside of the propellant use, other things to consider: raw materials, production process, having to use aero chambers or spacers. So all things to consider. So I'll hand it over to Dr. Demant to touch on pulmonary function testing.
Thanks, Tina. Thanks, Jackie. And good evening, everybody. So I have the unfortunate duty of taking you all back to first year medical school, and we're going to review some of the basic physiology. I guess it's not really an F word, but some people look at it that way, more of a PH word. So let's kind of go back and just kind of review what kind of information we actually get when we order a spirometry or a full pulmonary function test. So the term pulmonary function test, or PFT, kind of actually includes all three of the tests listed here. So spirometry, which has pre and post bronchodilator testing, you get a flow volume loop with that. And you get all those other kind of measurements like FEV1 and FVC. The second part is a lung volume measurement. And again, there's a long list of different lung volumes and capacities, the most important of which is total lung capacity. And then finally, diffusion capacity. And we're going to just kind of look a little bit at each of these in a little bit more detail. So next slide. Okay, so this is a volume time curve. On the vertical axis, we have a measurement in liters of the volume of gas that comes out of your lungs when you're blowing really hard. And along the horizontal axis, we have time in seconds. So I want everybody to just pause here for a minute. I want you to, right now, you're just kind of nice, relaxed breathing. I want you to take a deep breath in, inflate all the way up to total lung capacity, as much air as you can actually put into your lungs. And then you don't have to do this, but imagine blowing out as hard as you can, as long as you can, until you can't empty out any more air. So when you do this maneuver, this forced expiratory maneuver, you start with 0 exhaled air. You're at total lung capacity. And following the red line here, as you blow out really hard, at least if your airways are working properly, you should get out the majority of the air in the first second. In this example, about 80% of the air comes out in the first second. And then as you continue to blow hard, your lungs are getting emptier and emptier. As you approach residual volume, you're almost about ready to faint. This is the really hard part of doing a spirometric test, is the last few milliliters of air. You're squeezing as hard as you can, and eventually you get the total amount of air that comes out over however long it takes is called forced vital capacity. So this volume time curve is very helpful for measuring how well your air tubes are working. And in particular, what we want to do is we want to do a mathematical ratio of the amount of air that comes out in the first second divided by the total amount of air that comes out after the entire maneuver. So you can see up at the top, we've got an FEV1 or F over FVC ratio of greater than or equal to 0.75. In younger people, that would be considered normal. In an older person, and now that I'm approaching my late 50s, the definition of old is evolving in my mind, but with aging of the airways, the air tubes become a little bit less compliant. And so to be otherwise an older person that's completely healthy, we accept a slightly lower FEV1 to FVC ratio. So this graph here shows somebody who has normal airway function, all right? And mathematically, that would be indicated by that ratio of being greater than 0.75 in a younger person and greater than 0.7 in an older person. Next slide. Sorry, Tina. I threw a curveball there. Tina was anticipating, but okay, the other thing that we can tell from this forced expiratory maneuver is we can give a short-acting beta agonist like salbutamol, and then we can have the patient repeat the maneuver in 10 or 15 minutes. So if we have a normal volume time curve, the red line, 10 minutes later, it should be completely the same. The short-acting beta agonist will have absolutely no impact. On the other hand, if there is obstruction, so the blue line and the yellow line demonstrate varying severities of expiratory airflow obstruction. In other words, let's look at the blue line. Even though the patient's trying really hard to blow out, in the first second, they blow out relatively less than the person with healthy airways. The ratio of FEV1 divided by FVC is less than the 0.7 to 0.75. And after we give a bronchodilator, we might see one of a couple things happen. We might see absolutely no change, meaning that there's no bronchodilator responsiveness. We might see a partial improvement, a partial return towards the normal curve, indicated by partial reversibility, or we might see a complete reversibility. In the example of the person with severe expiratory airflow obstruction, the kind of gold colored line, if we gave a short-acting beta agonist and saw that they returned to having a normal FEV1 to FVC ratio, then we would say that that's complete reversibility. And in terms of the criteria that we use to define significant reversibility, there's some numbers down here at the bottom, a greater than 12% and greater than 200 milliliter increase in either FEV1 or FVC. But I would add that we also have to use a little bit of clinical judgment on top of that. If the patient can do more and feels better, has fewer symptoms, maybe a 10 or 11% improvement is enough to be significant. So that, there's a little bit of clinical judgment that that depends on that. Okay, next slide. So this, on the other hand, demonstrates the volume time curve of somebody that might have, let's say, morbid obesity, neuromuscular weakness, like let's say ALS or Duchenne muscular dystrophy or a spinal cord lesion, or they might be somebody with interstitial lung disease like pulmonary fibrosis, so a restrictive respiratory defect. And again, the volume time curve can be helpful in that it shows a reduction in both the FEV1 and FVC ratio. Now, Tina, if you go back one slide for just a second, the spirometry and the volume time curve is very helpful in identifying airflow obstruction and reversibility. But I want you to notice that in these examples of obstructive disease, like let's say somebody with asthma or COPD, the FVC is decreased in both. Okay, the FEV1 and the FVC are both decreased. And then if you look at the next slide, in a restrictive respiratory problem, again, the FEV1 and the FVC are both decreased. So the spirometry, the volume time curve, helps us identify obstructive problems, but we have to do some additional testing if we suspect a restrictive problem. Next slide. Okay, now at the top of this illustration, you can see that we've got a volume time curve. It's the exact same graph that we were looking at before. The only difference is we've rotated it by 90 degrees. And again, just like before, if you look at the point where the X and Y axes intersect, 0 and 0, that's total lung capacity. And then at about 4.5 liters, that would be forced vital capacity or residual volume. And the interval between total lung capacity, full, and empty, residual volume, is the vital capacity, the forced vital capacity. So another way of looking at the flow of air in and out of the lungs is to use a flow volume loop. And that's what we're seeing at the bottom part of this illustration. And in fact, this is a very normal looking flow volume loop. You can see that below the horizontal line, there's a small little loop in the center of this labeled normal breathing. And so that would just be what you're all doing right now. Nice, relaxed breathing. You breathe in, the lungs get a little bit bigger, air flows into your lungs. Then you breathe out, the lungs get a little bit smaller, air flows out. Then when after the technician starts really pushing you, and this is where we get the patient to inhale all the way up to TLC, they blow out really hard, and then they squeeze out from full to empty. You can see the black arrow is showing the direction that this goes. This is a very helpful tool in terms of, again, diagnosing our patients' abnormalities. So next slide. All right, so here are some representative flow volume loops. That at the top in the center, we have a normal flow volume loop. We've got the tiny tidal flow volume loop in the middle. We've got going from TLC to the peak expiratory flow, and then down to residual volume. We have a nice linear relationship. There's a straight line from peak flow down to residual volume. That's normal. If you look at the upper left flow volume loop, you can see in somebody with early airway disease, a little bit of bowing of that flow volume loop, in particular, where it says not okay. So that's one of the first things that we can see in somebody with mild asthma, or let's say if this was an older person who smoked for a long time, that might be one of the first physiologic manifestations of COPD. Further on the upper right corner or section, you can see somebody with more severe expiratory airflow obstruction. The blue dotted line again shows the normal flow volume loop, and you can see that in somebody with severe chronic asthma acute asthma or severe COPD, there's a marked decrease in peak expiratory flow. There's severe bowing of the expiratory limb of the flow volume loop, and everything is shifted to the left because the air is trapped in the chest. It can get in, but it can't get out. And clinically, when we see somebody in this kind of a state, when we examine their chest, we call that hyperinflation. Now, the last two at the bottom are variations of restrictive defects. So in those examples, we can see that the everything, all of the volumes, the TLC, the residual volume, are shifting towards the right, which is smaller lung volumes. So next slide. In order to confirm restriction, we have to do additional testing. So we measure lung volumes. Here you can see a spirometry on the left. Nice relaxed tidal breathing at first, then the patient takes a deep breath in, inflates all the way up to total lung capacity, then blows out really, really hard, squeezes all the air out. That's the forced expiratory maneuver that we were looking at before. And using those measurements, we can actually determine total lung capacity. If total lung capacity is reduced, as in the middle bar graph, then that is the definition of restriction. That would go along with those problems we talked about before, like morbid obesity, neuromuscular weakness, chest wall deformity, maybe interstitial lung disease or pleural disease. On the other hand, if we have somebody with chronic airway disease, the air can get into the lungs but then becomes trapped, we might see hyperinflation. And total lung capacity on the extreme right, that bar graph shows somebody, what we might see in somebody with severe hyperinflation due to obstructive lung disease. Next slide. Now, the final thing we can do in a full pulmonary function test is we can measure diffusion capacity. And this cartoon over on the left kind of illustrates that. In essence, what we do with the diffusion or diffusion measurement is we have the patient blow out all the way to, they empty their lungs, then they inhale, and as they inhale, they take in a very dilute concentration of carbon monoxide. Yeah, it's the one that can kill people if it's too much, but fortunately, it's just in a very small dilute concentration. And with this carbon monoxide in their lungs, they actually hold their breath for a full 10 seconds, and then they exhale again back to residual volume. And basically, what we're doing is we're seeing how much of that carbon monoxide diffuses across the alveolar capillary membrane into the bloodstream, binds to hemoglobin, and is taken away. And so we can use that measurement to tell if the lung, the alveoli are healthy or if they're not working properly. And if we combine that with the other information from spirometry, the FEV1 to FVC ratio, and lung volume measurement, then we can really get a very focused definition of what's going on. So for example, if you've got somebody who meets the criteria of obstruction and they have a normal diffusion capacity, so DLCO is just another way of saying diffusion, the kind of diffusion limitation for carbon monoxide. If the lung alveoli are working normally, then that would be in keeping with a disease confined to the airways, so asthma or chronic bronchitis. If the diffusion is low, then that would suggest that there's obstruction, that would go along with emphysema. There's problems with the airways, but the lung parenchyma is also sick and not working properly. And then in the setting of somebody with a low TLC, total lung capacity, again, normal diffusion would suggest there's a problem with something outside of the lungs, like morbid obesity, severe kyphoscoliosis, or some other chest wall deformity, maybe neuromuscular weakness from one of the things we talked about before. On the other hand, if diffusion is decreased in the setting of a restrictive respiratory defect, then that's kind of the hallmark for interstitial lung disease or maybe pulmonary vascular disease. So we can use these three different sets of measurement to really narrow down what's happening with our patients physiologically, and that helps with the clinical diagnosis. Next slide. Now, one of the things that's a bit overwhelming about a pulmonary function test or even just a spirometry is the amount of data you get. So this is a report on a patient who's had a full pulmonary function test. You can see that they have a spirometry, they have lung volumes, they have diffusion capacity measurements, and there's a whole bunch of demographic and clinical information up at the top. So one of the things you can do, there's two ways to approach this. One is to just go to the interpretation at the bottom and look at that. That's a little dissatisfying. It's actually a little bit more fun to kind of look and make sure it's the right test on the right patient, see if there's any clues in terms of their BMI, what their smoking history, if there's any diagnosis or medications. This person's got a history of chronic cough and has a significant smoking history and is on Advair and Spiriva. So those are some important clues as to what might be going on. Then you can look at the FEV1 to FVC ratio, the pre-bronchodilator one. And in this case, it's actually normal. It's 96% of predicted. And then after bronchodilator, there's no change really you can look at the flow volume loop and you can see, yeah, there's maybe a little bit of bowing of that expiratory limb, but it's not dramatically abnormal. Then you can look at, you don't have to really look at any of the other numbers here. You just look at the FEV1 to FVC ratio, the pre and post. The little green dots over here, the Z scores on the right-hand side actually help us as well. That's really, if the FEV1 to FVC ratio is way down, yellow or red to the left of the Z score mean, then you can say that's probably obstruction. Similarly, with lung volumes, the only thing you really need to look at the majority of times is the total lung capacity. And in this case, TLC is normal, so that's a normal. If you looked at, if it was off to the left, that would be in keeping with restriction. If it was off to the right, that would be in keeping with hyperinflation. And similarly with diffusion capacity, you can use that. You can use the Z score. So by knowing what to look at in the numbers, you can actually kind of narrow it down and it makes a lot more sense. Next slide. Okay, so there are exceptions to every rule, right? I mean, these are general guidelines that we use. People with asthma can generally be diagnosed if their spirometry is abnormal. Remember, asthma is a variable disease. So if a person has a very convincing clinical story, but their spirometry looks normal, that doesn't rule out asthma. It might be worth repeating the spirometry at some point in the future. Similarly, COPD, usually all you really need is spirometry. If you see fixed, irreversible expiratory airflow obstruction in the right clinical setting, you've got a diagnosis. With chronic cough, again, it depends on the history. Spirometry is a good start. Interstitial lung disease, undifferentiated dyspnea, long COVID in the right clinical setting, you should probably think about a full pulmonary function test. Next slide. Now, this whole presentation is meant to be a kind of a discussion. We're looking forward to your input into these recommendations and into these guidelines and some of the stuff that we're telling you today. The Medicine Network, and in particular the Respiratory Health section, in the last few months has developed this flow chart. The whole idea behind this lung testing quick reference test, or a guideline flow sheet, is there's going to be, you can't create a flow chart that is applicable to every last patient on the planet. This is meant to underscore some general principles. So for example, what we have here across the top is based on history and physical examination. What do you think the most likely diagnosis is? So a younger person who's never smoked, they have episodes of cough, wheeze, etc. The most likely diagnosis in your mind is asthma. Most asthmatics have normal chest x-rays. So unless there's something else going on, your red flags are kind of, your alarms are going off for some other reason, most asthmatics actually don't need a chest x-ray. And spirometry, pre and post bronchodilator testing, would be the most appropriate test. And again, this goes through some of the things you might see. If you had a patient with an older individual with a significant smoking history or occupational exposure, daily progressively worsening symptoms, you're suspecting COPD, you might be more inclined to do a chest x-ray. But spirometry would again be the most appropriate initial test. So chronic dyspnea, if you start thinking about interstitial lung disease, long COVID, dyspnea, NYD, there's other tests that you may want to, other approaches you might want to consider. And as we work through some cases in the next couple minutes, we'll look at this flow chart in more details. But we're very interested to find out what you think about this tool as a way to underscore some of the principles. I think that's my last slide. So back to Tina.
Thanks a lot, Ron. That's excellent. And I don't know whether I ever used the F word, but I think that's a great review for us. Thank you so much. So I'm going to call on Dr. Tay, and I'm going to ask her to help me because I've had some difficult patients recently in my clinic, and I want to introduce you to Edward. He's completely new to my practice, and he's got a history of hypertension and GERD, and he wants some prescription renewals. We asked about his cough, and he said he has a regular smoker's cough. Doesn't really bother him. He doesn't say it's productive, and he doesn't say he wheezes. Gets a little bit, he says, I'm getting older. I get a bit winded when I go and do the yard work, but I don't get colds. I don't get sick. But you happen to notice that there's an emergency room discharge note, and he was given oral steroids fairly recently. You actually go through the Canadian Lung Health Test questionnaire. And I'll just remind you of that I know that in the Edmonton Southside PCN, all clinics with QI support are helping their physicians to screen patients over the age of 40 with any smoking history so that they have a yearly tobacco assessment and complete the Canadian Lung Health Test. This includes a number of different questions. Do you cough regularly? Do you cough up phlegm? Do you get breathless, etc.? And this gentleman, his score is 2. So he has been referred, in the past, he says, honestly, every single person I see tells me to stop smoking. Can't do it, not interested. So let's have a think. What testing might you order for my patient, Edward? And if we could have the poll launched, and then we'll check to see who's still engaged and awake, and you're going to get 30 seconds to answer. So we'll put a little bit of time pressure on you. It's always nice when you can see it appearing in front of your eyes there. I think they might have been listening. There we go, 30 seconds. Jackie?
Okay. Oh, great. Yeah. So the results are shared there. So we'll kind of go through these one by one and try to determine, as per the flow sheet, trying to apply that flow sheet to this case scenario, what might be the most appropriate. So a chest x-ray that might not be totally inappropriate in this case. As we recall in that flow sheet, one of the first steps there in someone who's older, smoking history, has a cough, might be reasonable to start with a chest x-ray, again, not to miss any other pulmonary diagnoses, and particularly with that significant smoking history, not wanting to miss something like a malignancy. So definitely not a bad place to start. A full PFT, as we had talked about, if we are suspecting COPD, may not be totally necessary in this case, but if he has some other additional risk factors, occupational history, and other concerning symptoms, then you may want to consider doing a full PFT. An ECG in this case, I guess thinking about kind of cardiac diseases and a cardiac cough would be something to consider as well, but he doesn't really endorse the history of having chest pain or anything like that, but yep, something to consider as well. And then spirometry. So again, thinking back to our diagnostic criteria for COPD is that we are in someone who we are suspicious has COPD with this significant smoking history, typical symptoms such as coughing, shortness of breath, that fits that demographic, and you are wanting to assess for COPD, then spirometry to look for fixed airflow obstruction without any bronchodilator responsiveness will give you your diagnosis of COPD. So a good place to start is less intensive than doing the whole PFT and may give you your answer off the bat. So that in this case would probably be the most appropriate place to start, unless there's again red flag symptoms. He's coughing up blood every now and then that he's not telling you about or anything like that. But that emergency department history where he was probably treated for a COPD exacerbation as well is something to think about as well.
Absolutely. So, okay, can we get rid of the last? I can still see the polling question. If you can still see the polling question, just clear it off your screen with the X. Okay. Jackie, do you want to?
Yes. So the next question here. So going back to the physiology. So given that Edwards spirometry performed shows moderate airway obstruction with no reversibility, which of the flow volume loops would be most in keeping with this finding? And we'll start the poll, please.
I always find this interesting. How do I match it to what Dr. Demand was saying? Okay, we've had our 30 seconds.
Do you mind just going back one slide there, Tina?
Oh, yes, I certainly will.
Thank you.
Yeah.
Okay, great. So the majority of people answered A, which is the correct answer in this case. So again, this demonstrates that bowing of the expiratory limb indicative of airflow obstruction on expiration. These other examples here, B demonstrates a restrictive defect, which again shifts that entire lung volume smaller. C and D are actually examples of airway obstruction. So C is an example of a fixed airflow obstruction, airway obstruction, such as tracheal stenosis, where there's a limitation both on inspiration and expiration that doesn't move with those different airflows or pressures in the chest. And then D is an example of an extrathoracic variable obstruction in the airway. So A, again, demonstrating that scooping or the bowing of the expiratory limb is the correct answer in this case. Next slide. So this is again just to touch on that the flow sheet in this case. So generally an older patient over 35, chronic tobacco use or potentially occupational exposures having progressive, whether they endorse it or not, symptoms of coughing, wheezing, phlegm production, or if they've got a family history of COPD that you've been able to elicit. And you're suspecting COPD, again, you may want to consider that chest x-ray, particularly given that significant smoking history and progressive symptoms, or if you've got any other red flag symptoms, and then spirometry to help you come to that diagnosis of COPD. Next slide, please.
Excellent. Okay, so my next patient is Kyle. He's been a patient forever, and he's 39 now, and he comes in with another episode of bronchitis. Seems to happen in the winter. He uses a short-acting beta agonist, and that really helps his cough and his wheeze. He can't really say that there are any other triggers. He's well otherwise. He's got a little bit of a cold. Family history, yep, there's some asthma there, and he was born preemie, had a little bit of eczema when he was a child, not smoking, never been exposed to smoke, no GERD, no allergies. He did actually have a full PFT 5 years ago, and because I hadn't been to this lecture by then, and I, of course, didn't realize that spirometry would have been the right thing to do. So I ordered a full PFT. It was normal, but here we are today, and I need some help. So what are we best going to do to figure out what his diagnoses are? Because
oh, maybe I'll read out the poll there. We lost Tina with her Wi-Fi. So what is the best way to determine his underlying diagnosis in this case? Is it A, starting him on a trial of inhaled steroids and increasing his Ventolin or SABA use? B, repeating his spirometry? C, no further testing. His previous PFT was totally normal. D, bronchoprovocation testing, or more commonly methylcholine challenge testing, i.e. referring to a specialist. E, chest radiograph, or F, referring for endoscopy. Can we start the poll, please? Okay, we'll end the poll there. Thank you. Perfect. Okay, so yeah, so the majority of you mentioned that repeating the spirometry in this case might be a reasonable place to start. A couple of caveats. So trialing inhaled steroids, increasing Ventolin use, as you may recall from the choosing wisely point, that you want to, of course, confirm the diagnosis with some sort of confirmatory testing, spirometry, bronchoprovocation testing, exercise testing, should those tests be available in a timely manner. Unfortunately, during the pandemic, the methylcholine challenge became very untimely, was taking upwards of a year to obtain. And so in patients who have had repetitive normal spirometries, a year is getting a little bit long time to wait in terms of having persistent and repetitive symptoms. And so again, in the right clinical context, doing a trial of inhaled steroids might be reasonable to see if they may have some improved pulmonary function testing or peak expiratory flows. If you do happen to come across the GINA guidelines or the CTS asthma guidelines, there's a number of different ways that we can diagnose asthma. The criteria that Dr. Demand had mentioned in terms of the FEV1 improvement of 12% and 200 cc's with bronchodilator use is kind of the most commonly recognized and kind of very easily obtainable with spirometry. So that's kind of the more common one. But again, if you can do trial of steroids and doing peak flows, difficult to manage in the outpatient without kind of repetitive follow-ups. So probably not the most best use of your time. Repeating the spirometry in this case to see if he's developed any or meets any diagnostic criteria for asthma, again, would be the most useful way of establishing his diagnosis. And again, remembering that asthma is a variable disease, right? So they're going to have good days and bad days. And if you're able to catch them on a bad day and demonstrate some airflow obstruction with bronchodilator responsiveness, then again, that's going to help you confirm your diagnosis. No further testing. His previous PFT was normal. He's having kind of repetitive episodes of these, and so better to kind of sort out some kind of testing for him to figure out what's going on. Bronchoprovocation testing, I think I saw in the chat box there, if methylcholine challenges are still being used. As I mentioned, they are used. They do need to come from a specialist referral, but probably not the first test to jump right to, again, because spirometry is so readily available. And if you're able to demonstrate that airflow obstruction with bronchodilator responsiveness, then that will help you, again, confirm your diagnosis. And then referring endoscopy, I had thrown in there just in terms of looking for things like heartburn, reflux, that may be a cause of his chronic cough, but that kind of variable nature, seasonal aspect of it is probably less in keeping with something like that. Okay, I'll stop sharing that one and we'll move on to the next slide. Actually, what time is it? 6:10. Okay, sorry, let me just, oops, sorry, wrong way. Okay, so the last case, oh, sorry. So again, just touching on the flow chart here. So in patients with kind of that those episodic dyspnea, wheeze, triggered by cold air, exercise, infection, allergens, might have a personal history of atopy, and you're suspecting asthma. Again, most asthmatics, as Dr. Demand mentioned, typically don't need a chest x-ray again, unless you have any alarms that are going off and red flag symptoms. But doing the spirometry to again look for that airflow obstruction. Further down on the chart here, this is just the top half, but again, Dr. Demant had also mentioned that a normal spirometry, as we've touched on, does not rule out a diagnosis of asthma. So again, trying to do those spirometries to confirm the airflow obstruction. Okay, and we'll do this case quickly. So Josephine is a patient, often lost to follow-up. She's experiencing summer seasonal shortness of breath, productive cough, wheezing, and chest tightness. She does take antihistamines as needed, which seem to help. In 2020, she was admitted to the emergency department, received a chest x-ray for acute cough and dyspnea. The results indicated hyperinflation queries COPD. At that time, she was discharged on cefuroxime, prednisone, inhaled tiotropium. She did not appear for her follow-up lung function test appointment. You're seeing her in follow-up. She's currently not using an inhaler. You send her for spirometry now that she's shown up. And the results demonstrate an FEV1 over FVC ratio of less than 0.7 and an improvement in FEV1 of 15% and 270 milliliters. She doesn't really have any significant family history. She does have a significant smoking history, however. She had done some lung function testing due to her long-standing respiratory symptoms in her 30s, but these results are unfortunately not available. And to her knowledge, she doesn't really know what the diagnosis was or what the results of those testing were. So, so last question here, what additional testing is needed in this case? Is it A, repeat pulmonary function testing with lung volumes and diffusion capacity, repeat spirometry, bronchoprovocation testing, no further testing, or does she need a CT chest? We could start the poll, please. Okay, we'll end that poll. Thank you. Okay, so the majority of you have indicated that she may benefit from a repeat PFT, full PFT with lung volumes and diffusion capacity. So this question I was trying to get at that she did indeed. Sorry, I'm just trying to go back up. Again, with those spirometric criteria, she does have an evidence of airflow obstruction, and she also meets the criteria for bronchodilator or significant bronchodilator responsiveness with FEV1 of 15% and 270 milliliters. So she does meet the diagnostic criteria for asthma and does have some kind of these intermittent episodes as well that respond to prednisone and inhalers. So in that case, you could consider no further testing and actually start her on therapy for that to see if she has a symptomatic and lung function improvement. In terms of repeat pulmonary function testing, she is an older individual. We didn't really have any other comorbidities. And so in terms of looking for things with the lung volume, so maybe you're looking for hyperinflation or again, abnormalities with diffusion, that might explain her symptoms. But you've got a pretty good reason based on the spirometry for her symptoms. Repeating the spirometry might be useful once you started her on therapies and you want to monitor how her lung function is doing, again with repeat clinical assessments as well. CT chest, you might want to think about if she had any, she does have that significant smoking history, so it might be worthwhile to look for things like impaired diffusion on the PFT, that might suggest emphysema, or obtaining a CT chest, again, also to look for emphysema. But I think in this case, starting that spirometry gave you pretty good information, and starting her on a trial of therapy to see how she does would be a reasonable place to start. Okay, so again, this is just to again touch on the diagnostic criteria. And here's that part here, that normal spirometry does not exclude asthma. Okay, so just in terms of some pearls here before I hand it back over to Nandini. So again, do order spirometry when you're suspecting asthma, COPD, or chronic cough. Do order complete lung function testing, i.e. a full PFT when suspecting ILD or undifferentiated shortness of breath. And then doing an objective measurement of lung function testing before a trial of medication so that you can monitor their progress or their response to therapy. And then consider using the HQCA panel report for lung testing for asthma and COPD. And
thanks so much, Jackie.
Oh, no problem.
I'm back, but I'm so thank you for sorting my patients out for me. That was really helpful. And yeah, we'd love to hear your feedback about that flow chart. So please, if you have an opinion about it, if you'd like to give some feedback, we're hoping that this will be disseminated more broadly and help us in our decision making going forward. So that's the email to get in touch with. And I think that's the end of this slide deck, I do believe. Leslie, over to you.
Hi, thank you so much, presenters. We appreciate all of that. And it was great information. So we are now going to talk about the application of learning portion of this workshop. I just wanted to share a continuous quality improvement story from one of the Edmonton Southside primary care member clinics that I support with Otwell Medical Clinic. This ties nicely into the workshop that we're doing this evening. Our journey to date, going back during the pandemic in January 2021, Dr. Marcette wanted to identify her patients who were 40 plus years of age with a current or past smoking history and without a diagnosis of COPD. Once we identified these patients on her panel, she was interested to know how many of them had been asked the Canadian Lung Health Test questions. So on our journey to date, we started with a few strategies that looked at reviewing and revising the clinic's annual lifestyle questionnaire, which included tobacco questions, tobacco history questions. We also looked at revising that and adding a few more detailed tobacco questions. We decided to add in the CLHT questions to this annual lifestyle questionnaire, as well as we utilized the EMR by adding some EMR triggers and some goals for annual tobacco screening to make sure all patients had this done. And as you can see in this graph, since January 2021, none of the patients had been asked the CLT questions based on review of chart notes. Since implementing those strategies I mentioned above for Dr. Marcette's eligible patients, we see a nice steady increase to where now 50% of her eligible patients have had the CLHT administered. So this project is still ongoing and has stages. And so now this project has piqued interest to the other physicians at the clinic, to where the clinic's annual QI plan or quality improvement plan will be based on this project and will be used for their PPIP, which is the physician, practice physicians improvement program through the college. So I'd like to thank Dr. Marcette very much for allowing me to share data of hers. So again, now that we're in the application of learning portion of this workshop, it's now time to apply your knowledge that you obtained today to your clinical practice. So the action plan that was attached to the remainder to your reminder email, and will be shared in the breakout rooms with you today. It's a 2-page document. If you wish to submit this action plan as part of your linking learning to practice document, you can do so. On the action plan itself, you will notice that there are 3 goals. And depending on your current practice and clinical processes, you may decide to focus on one goal, or you may decide to action on more than one. Just remember, it is important to stay with at least to identify 1 or 2 priorities and not to go to gung-ho. So just going to make sure I didn't miss anything there. Yeah, so our next slide here is, so to help you with, identifying some of your patients who fit in this category of eligible patients, you can use your Health Quality Council of Alberta Primary Healthcare Panel report, which is available to everyone, proxy report if you choose to sign up. And another way that we can assist you with identifying these patients is, I'm speaking for the Edmonton Southside Primary Care Network, is we give our physicians quarterly reporting data on their screening rates, panel demographics, and their access. So included in these reports quarterly would give you some idea on your patients and how you're doing with tobacco screening. As well, you can always, and we do encourage this, is use your EMR. It needs to be the hardest working team member in your clinic. And we can help you with that, your improvement facilitator. You need to consider how and where you're putting that information about your patients in the EMR so that we can easily be able to pull that data for you. Billing codes, problem lists, medications, observation chart notes. These are some of the things that we can definitely assist you with. So this is some examples of how we can help you identify your patient population. So this slide is just an example of the HQCA reports. Then the latest reports actually came out today, which is April 4th, and they include the chronic disease data on asthma and COPD in your panel. And as you can see here, it will also, it gives a percentage of patients, I believe, with spirometry and/or pulmonary function testing. So if you wish to explore this report to guide your quality improvement work, please let your improvement facilitator know, as we are happy to work with you. The reports also provide information on patients' continuity, screening, vaccination rates, chronic conditions, including asthma and COPD, pharmaceutical use, and emergency and hospital visits. The report may be, again, a proxy panel report, or you can also request a confirmed panel report. So again, make use of these great resources that are available to you. Sorry, this is the additional slide to where you can find that information in your Health Quality Council report. So another one of our, I felt like I missed a slide here. I also wanted to just speak to briefly about how another resource, a really good one, is CISE-PAR. So I'm sure you've all heard about this initiative, and CISE-PAR is a great tool to bridge primary care to the rest of the healthcare community, especially for your patients who have chronic conditions, so that you can, so that the rest of the healthcare world knows that you are, that a patient is attached to you in the primary care setting. So we do encourage you to participate in CISE-PAR, and again, talk to your primary care network manager or improvement facilitator for more information about that. Going back to our action plan that everybody's going to be talking about in our breakout rooms, in a moment. There are 3 areas or 3 goals that we're giving you as ideas for an action plan to work on. The first one is looking at eligible patients, as we did at Otwell Clinic, patients 40 plus with any type of smoking history, and have they had any sort of tobacco assessment or been assessed with a Canadian lung health test. So you can use, again, your EMR. Make sure you use your EMR to identify these patients, identify if they need to be annually screened. You can also, and that's an opportunistic way. Another way that you can reach out to patients that you have identified is to do it on an outreach basis. So here at the primary care, Edmonton Southside Primary Care Network, we do have panel care coordination assistants who help with that panel management and screening and outreaching to patients to make sure they don't fall through the cracks. So that's one of the goals that you could do for your action plan. Another one is looking at those eligible patients with who's had a complete appropriate lung testing to confirm diagnosis, and looking at those patients and making sure that we can have the management in place, looking at certain team members that are working in your clinic can also participate in this work. It's not only doctors' work. So that's another goal or area you can work on with your action plan. Another goal, our last goal that we will, is more focused towards the primary care network members, looking at eligible patients with confirmed chronic lung disease, because they can be referred to the Edmonton Southside Primary Care Network COPD and asthma clinic. And so again, that is specifically for our ESPCN member physicians, that you do have access to this COPD and asthma clinic to support your patients. So it's, again, identifying the patients and looking at to see who can be who would be eligible to be referred to the clinic once they've been had a diagnosis. Okay, again, we're going to drill this into you with the primary care network, is that we really want you to use your team members. Here at the Edmonton Southside Primary Care Network, we have a lot of multidisciplinary team members, which include our registered nurses. We do have nurse practitioners. We do have exercise specialists, registered dietitians, behavioral health specialists. And those are all those team members that they're waiting for you to utilize them and put them to work for your patient care. So there's my CIC PAR slide. I thought I missed it. So again, join the movement towards integration and bridging primary care to the rest of the healthcare community, and especially for continuity of care. And again, just touch base with your improvement facilitator if you want more information on CIC PAR, or if you just want to sign up, we can do that quickly. Moving on, we are now ready to go into our breakout rooms to discuss have a great discussions about what we learned from the presenters, and to talk about your action plan. So I'm going to leave it up to Shanna and Kim to put everyone into their breakout room. Thank you.
So I think we're moving straight into the panel Q&A now, I believe. So I think any questions that anybody has about any part of this evening, just ensure that you've popped them into the Q&A. Right now, we've just got a couple of pretty focused questions, but I do know that in one of the rooms that I was just popped into, there was a question about whether we're going to get documentation on the Canadian lung health test, and if one of the team could just answer and reassure that we're going to get all the relevant details of that. I believe it's good. Yes, Ali's got a thumb up. So we've got all the members of the PCN, we've got our specialists, we've got Oliver, David, and we also have Colleen. I'm going to mess your name up, I know I am, but it's Makarovsky, right? And Colleen is a respiratory therapist, a very experienced respiratory therapist working in primary care for a number of years. And she's been supporting physicians within the ESPCN in reaching their goals with their patients with pulmonary disease. So welcome, Colleen. So as we go, let's just have a look at the questions now. And I'm going to just start. There was a question from Karim Simar and Jessie Haddock. When would be a good time to order a methacholine challenge? And that would a PFT suffice if there is normal spirometry? So I think that's probably one for Dr. Tay and Dr. Demont. I don't think that's really, it's not applied to any particular patient, but can we hear your thoughts?
Go ahead, Jackie.
And sorry, that was so a normal PFT in this in the setting where you're suspecting asthma, I'm presuming.
So the question was, when would be a good time to order a methacholine challenge? So presumably you've done a spirometry and it's fine. And then do you go to a methacholine challenge at that point, or do you do a PFT? I think that's kind of where this question is heading for.
Okay, I see. So similar to our case with Kyle, so in the setting where someone has had recurrent respiratory symptoms, has had a normal spirometry or PFT previously, it wouldn't be unreasonable again to order another spirometry, just again because they're so readily available. They can help you confirm the diagnosis if abnormal, just as well as a methacholine can. With the methacholine, they are, and Ron can correct me if I'm wrong, in my experience, I'm not sure that they can be ordered from primary care. For us, we typically send our patients to the K Edmonton clinic, PFT lab for methacholine challenge. I believe there are some private options out there. I've not personally referred to those clinics before, so I'm not sure if there's certain criteria or patients that they will accept. But I would say, I think Dr. Demant had answered this earlier too, is if they've had a number of normal spirometries, but you're still really suspicious that they have asthma, just given their presentation, they've got strong family history or personal history of atopy and allergies, then that would be a reasonable next step for sure.
Yeah, and just to add, thanks. Sorry to put you on the spot, Jackie. I'll just defer all the difficult questions to you. But yeah, there's a number of different challenge tests that we can use in the setting where we have a fairly suggestive history, but the spirometry is normal on repeat testing. And so, methacholine is, like, I call it an asthma stress test. People with normal airways that are not inflamed and not asthmatic won't respond to the methacholine, whereas other people, if they have inflammation and irritable airways, then they'll actually have a drop in their FEV1 with increasing exposure to increasing concentrations of methacholine. We also do exercise challenge, so we'll put people with suspected exercise-induced asthma onto a bicycle or a treadmill. And again, we'll just see if their FEV1 drops with increasing amounts of effort. Those are both kind of specialist referrals. I think in both Calgary, Edmonton, and rural Alberta, you have to have a respirologist see the patient first for that to be done. There used to be a lab at the U of A where we would do specific allergen tests. They'd inhale allergens and we'd see if we could provoke, but that's kind of dangerous and it's very expensive. And unfortunately, we don't have that anymore. Unfortunately, as well as Jackie alluded to before, the list for methacholine has really backed up since the pandemic happened. So we're taking a bunch of steps to try and get on top of that.
I think that's what I've noticed, that trying to get patients in for any testing is actually quite difficult now. The wait time is quite prolonged, and it's I enjoyed listening to that answer, because I didn't put it as well as you guys did, but I actually tried to explain that to a patient today about whether or not she needed a methacholine challenge or not, because she'd had a normal spirometry. And another thing that often comes up is the question of interval and repeat testing. So, you know, when you have a patient, let's say a patient with asthma, and you have them on medication, you know, it's quite easy if they're brittle, if they're poorly controlled, we know that they need repeat testing. What about any other significant indications that we need to remember about to make sure they've had testing done?
I'll start off this time, I guess. You know, I think we're trying to find the sweet spot between two extremes. So you know, I'm old enough to remember when there was one or maybe two labs in Edmonton. If you lived in northern Alberta, the northern part of the province, and needed any kind of lung testing, you would drive for 8 hours to come into the city. And even people that lived in the city would, you know, not have access. So that's, you know, the one extreme where people who had COPD or asthma would just not have access to it. The other extreme would be where, and I'm not going to point any fingers at anybody, but, you know, sometimes we see practices where people are being told they should come in for their quarterly PFT. And you know, that's an absolute abuse of the system, and it's, you know, it's not indicated. So, you know, you need to use clinical judgment. There are times where, you know, if your patient is not doing well, they're having ongoing difficulties, repeat testing is probably warranted. With people with COPD, there might be times where you want to follow up, you know, in a year or two and see if there's been some progression. We know that COPD progresses even when we've intervened optimally. So, you know, that's my opinion about the whole thing. I noticed Oliver's hand is up, so I don't know if he has some insights he'd like to share.
I don't think I have insights. I had more questions, but are you going to hand the rest of that question off, or or you think you're pretty?
Unless Jackie or Tina, Colleen, do you want to? Mina, anybody? Eileen, anything to add?
I guess I would add that just to kind of add to Ron's point. I would say that with my PFT or spirometry ordering, again, we tend to do follow-up spirometry for patients with small airways disease, rather than, there's no sense putting them through an entire PFT. It's exhausting. It's not fun for the patient. It's time consuming. It's resource heavy. When there's lots of people waiting for testing too, like we're experiencing backups even with that kind of testing where it used to be so readily available too, but still trying to catch up from the pandemic as well. But I would say it often, there's no rule about interval testing. It would typically reflect my practice in terms of how often I'm following up with them. So if they're very poorly controlled asthmatic, for example, and I'm changing their management every 3 to 6 months, and I want to see what their response to therapy is, then yeah, getting that PFT spirometry every 3 to 6 months is going to be very helpful in guiding therapy, in addition to their clinical assessment and symptoms, right? But otherwise, we have very stable COPD patients in our population where they might get a spirometry or a PFT once a year just to make sure their emphysema and their COPD isn't progressing too much. You know, to keep in mind that these people, again, they progress. At what point do they need oxygen? Is their emphysema progressing to that point? So yeah, there's no right answer or kind of guideline answer for that, unfortunately. But
I'll just add briefly that you don't see a lot in the literature, national, international, or provincial, about the frequency of repeat and the types of scenarios where you would repeat. But it is something that's on our radar to build some provincial consensus around. May take us a couple of years, but it's on our minds.
And I think it becomes very relevant when we're looking at our list of patients that might have had a remote diagnosis, and yet we've got we haven't got any testing available. If they're doing all right, we might put it on a to-do list, but we're going to have to triage a little bit because of the long wait times. I've got 2 patients right now who are waiting to be seen. Both have had one's had oral steroids 3 times in the last, 4 months, and is now on triple therapy. And, I would really like her seen, but I keep getting a little note to say she's on a wait list, and I'll wait another 3 months and then I'll get another note to say she's on a wait list, and hopefully try and manage her in the meantime. But these are the challenges coming out of the pandemic, I think.
Was that for methacholine, Tina, or something else?
I was actually, she's a lady that she's had a spirometry in the past. She's got normal chest x-ray, but she's never smoked, but she's got a huge passive smoking history. And I think this is what we don't often ask. And I must admit, I don't think it was particular. Well, I've changed EMR and all sorts of things, and it wasn't recorded. And, she grew up with chain smoking parents. And here she is now in her 7th decade, and struggling, but with no obvious sort of trigger other than that things are getting worse. So I was actually hoping for, a respirologist to see her as well, because they've done everything else. I mean, she's, she knows how to use inhalers, and so we'll see. There's a question there from Maria, which is really interesting. It's something that I often asked when I first came over from England. Are peak flow meters used in clinics? But let's say, have they any relevance, and are they useful? Colleen, maybe you can talk.
I mean, I could take that, I guess, from a PCN standpoint. I get asked that quite a bit from the family physicians that I work with, and there's not a lot of support, I guess, in the data to say that peak flows. I think there's too many errors, or too many potential errors that a patient may do if they're doing it on their own. It's not, I've had a few clinics where they've had peak flow meters in the clinic. And we do see this in the emergency room departments as well, where they'll do a quick peak flow reading. So again, it might be something in the moment to give you a little bit of information in terms of what's going on with the patient, but long-term use of the peak flow meters, I think we kind of have put them off to the side a little bit. Maybe with action plans with asthma patients, again, if they are poor perceivers, they might have that opportunity to be taught how to monitor using their peak flows and add that numbers to their action plans. That's a potential, I think. But again, very patient specific, and a lot of trust, I think, has to go with that patient to have them follow the peak flow idea. That would be my end of it.
Yeah, Colin brings up, oh, sorry, go ahead, Oliver.
I was going to bring up a question quickly, because I know we're getting short on time. So I think the challenge will be, so if there's difficulties getting tests, and one of the right place, right time, right test recommendations is your patient, don't start an inhaler unless you've got a test. And so how do you manage that dynamic? Like, is a clinical response a good enough test? Like if you had a nebulizer in your office, you provided nebulizer, you get an improvement in wheezing, is that reasonable? And then follow up with additional testing, or what are your thoughts?
Well, I think, Jackie alluded to this, and you bring up a really critical point in that maybe we're going backwards a little bit to that time that I alluded to, where there wasn't, there's this much demand for tests and this much capacity. So, again, there are times where I think we have to use clinical judgment. I think that, sometimes I'll see people with an absolutely classic asthma, atopy, allergy history, and yet their spirometry is normal a couple times in a row. And I know it's going to be a 12 or 14 month wait for them to have a methacholine challenge. So I initiate treatment and I follow their response. So that's the first part. Sometimes we have to kind of use our clinical judgment and go with that, even if we can't access the test. The second thing is I think we need to lobby within the system to have adequate, I think it's actually inadequate that a patient in Northern Alberta has to wait 12, 14, 18 months for a methacholine challenge. That's kind of state of the art kind of, and similar issues are across the healthcare spectrum. So I think we need to lobby for it in a professional way, but I think we need to kind of promote, it's part of promoting good health and good respiratory health.
There's just one further question